At the end of an ordinary day, 4 objects may be within reach. A television remote sits beside the chair. A pain reliever waits in the medicine cabinet. A can of soup is ready for a quick dinner. A sweet drink is cooling in the refrigerator. None of them looks like a kidney emergency, and most people would never place them in the same story. That is precisely why the pattern is easy to miss. Kidney disease often develops with few symptoms, so feeling normal does not prove that filtration is normal. The concern is not that one afternoon in a chair or one sweet drink suddenly destroys healthy kidneys. It is that familiar choices, repeated for months or years, can make blood pressure or blood glucose harder to manage, add more sodium than expected, or expose vulnerable kidneys to a medicine-related injury. If you are over 60, this matters even more when you have diabetes, high blood pressure, heart disease, known kidney problems, or several medicines to manage. Today, we will follow those 4 objects through one normal day and make 4 practical checks. The last check happens in the kitchen, where a habit many people still think of as harmless may be the one most closely connected with long-term kidney damage. Before we reach it, the first clue is already beside the chair. Hours can disappear quietly when the morning news becomes a television program, lunch becomes a nap, and the evening ends in the same seat. Sitting is not a toxin, and it does not directly shut off the kidneys. The better supported concern is what a mostly inactive routine can do to the conditions surrounding kidney health. Less activity can make weight, glucose, blood pressure, mobility, and physical function more difficult to manage. Diabetes and hypertension are 2 major drivers of chronic kidney disease, so the daily movement pattern belongs in this conversation. This distinction matters because frightening explanations can lead to the wrong solution. You do not need to believe that your kidneys are being starved of blood every time you sit down. Rest is valuable, particularly during illness or recovery. The useful question is whether rest has gradually become nearly the whole day, leaving no regular opportunity for your muscles, heart, balance, and joints to work within their abilities. Think through yesterday rather than guessing. How long did you remain seated after breakfast? Did you move between television programs? Was lunch followed by several more hours in the chair? Did pain, dizziness, fear of falling, shortness of breath, or a lack of safe space keep you still? The answer is not a judgment. It tells you which barrier must be solved before advice about exercise can become realistic. For someone who is steady on their feet, a 5-minute walk through the house, down the hallway, or outside with appropriate support can count. A few minutes after a meal may be easier to repeat than one demanding workout. Standing during a commercial, carrying a cup to the sink, or walking to another room creates a natural interruption in a long sitting period. Small sessions accumulate, and a modest beginning is safer than trying to recover years of inactivity in one weekend. If standing is not safe, movement does not have to disappear. Ankle circles, heel lifts, gentle knee extensions, and slow arm movements can be performed in a stable chair if they fit your medical and physical limits. Someone with severe balance problems, recent surgery, chest symptoms, or a condition that changes exercise safety should ask a health professional or physical therapist for an appropriate plan. The objective is not to meet a dramatic number on the first day. It is to replace some inactive minutes with movement you can perform consistently. The household can make that easier or harder. A loose rug, poor lighting, a pet underfoot, or shoes without support can turn a sensible movement break into a fall risk. Clear a short route and place a stable chair where a rest may be needed. If another person is available, make the first few walks together. The best routine is not the one that sounds most athletic. It is the one the person can begin without fear and repeat without needing several days to recover. Public health guidance for adults 65 and older combines aerobic activity with muscle strengthening and balance work. while also emphasizing that some activity is better than none. That broader goal cannot be reduced to a rigid alarm every 45 minutes. A timer can be helpful, but your abilities, fall risk, treatment plan, and symptoms determine what is safe. If you become faint, develop chest pressure, or experience unusual breathlessness, stop and seek appropriate medical advice. There is also a more human reason to begin gradually. A person who has been inactive may wake up sore after doing too much, decide movement was a mistake, and reach for a familiar bottle in the bathroom. The attempt to correct the first habit can then reveal the second one, because pain relief is where kidney risk often hides in very small print. Over-the-counter does not mean harmless for every person or every situation. Non-steroidal anti-inflammatory drugs, commonly called NSAIDs, include medicines with active ingredients, such as ibuprofen and naproxen. Diclofenac is another member of this group and can appear in prescription or topical product. These medicines can be useful, but they can also reduce blood flow through the kidneys. Higher doses, frequent use, long use, and use during dehydration can increase the chance of acute kidney injury or worsen existing chronic kidney disease. Risk is not determined by age alone. It can rise when kidney function is already reduced, when a person has diabetes, high blood pressure, heart disease, vomiting or diarrhea, or when they cannot drink normally. Diuretics and certain blood pressure medicines may also be part of the clinical picture. That does not mean those prescribed medicines are bad or should be stopped. Some protect the heart and kidneys when used correctly. It means a clinician needs the whole medication list and the current situation before giving safe advice. Imagine a weekend when arthritis is painful and a stomach illness makes eating and drinking difficult. The person keeps taking the usual prescriptions, then adds an anti-inflammatory pill because it has worked before. Each decision seems reasonable in isolation. Together, low fluid intake, illness, and the added medicine may create a much less forgiving situation for the kidneys. This is why a sick day plan should be discussed before the next illness, not improvised when the person is weak and dehydrated. The first safety step is not throwing pills away. It is identifying the active ingredient. Brand names and package colors change, and the same ingredient may appear in a pain product and a cold or flu product. Put every prescription, over-the-counter, medicine, vitamin, and supplement on one list. A pharmacist can look for duplicated ingredients, interactions, and products that deserve special caution with your kidney function. Record how the medicine is actually used, not only the directions printed on the box. 2 tablets most mornings tells a different story from 1 dose after an occasional injury. Include creams, gels, powders, and combination cold remedies, because the route and label still matter. Bring the latest list to appointments and use one pharmacy when practical, so a professional has a better chance of seeing the entire pattern instead of one purchase at a time. Ask specific questions. Is this product an NSAID? How many days is it appropriate for me to use it? Does my latest kidney result change that advice? What should I do if I am vomiting, have diarrhea, or cannot keep up with fluids? Is there a safer way to manage this particular kind of pain? Specific questions produce more useful answers than asking whether a familiar brand is generally safe. Acetaminophen, also known as paracetamol in many countries, is different from an NSAID and is generally considered safer for the kidneys at recommended doses. It is not automatically the right answer for everyone. Taking too much can injure the liver, and it is included in many combination products, making an accidental double dose possible. Liver disease, alcohol use, other medicines, and the source of the pain all affect the decision. Read the active ingredients and confirm the plan with a clinician or pharmacist. Non-drug measures may reduce how often medicine is needed, although they do not replace an evaluation of new or severe pain. Heat may help some kinds of stiffness, while cold may be useful for certain injuries or swelling. Proper footwear, pacing activities, physical therapy, strengthening, and an assistive device can address parts of the problem a tablet cannot. Sudden severe pain, a hot, swollen joint, a fall, weakness, numbness, or pain with chest or abdominal symptoms needs assessment rather than repeated self-treatment. Notice how the danger became clearer only after reading the small drug facts panel. The dinner package uses a similar hiding place. A person can remove the salt shaker from the table and still consume a large sodium load because the next habit is often built into foods before they enter the home. Sodium is not limited to food that tastes intensely salty. Bread, deli meat, canned soup, frozen meals, pizza, sauces, dressings, cheese, breakfast foods, and restaurant dishes can each contribute. A single item may not appear remarkable, but breakfast, lunch, dinner, and snacks can combine into a total the person never intended. The relevant number is on the nutrition facts label, not in the impression left by the first bite. Too much sodium can encourage the body to retain fluid and can make blood pressure harder to control. Over time, uncontrolled hypertension can damage blood vessels in the kidneys. If chronic kidney disease is already present, sodium and fluid goals may become even more individual. This is not a reason to fear every milligram. It is a reason to see the total pattern and follow the target provided by the health team. For the general population, the daily value shown on United States food labels is less than 2,300 milligrams of sodium per day. That number is not a personal prescription. A clinician may recommend another target based on kidney function, blood pressure, heart health, medicines, and laboratory results. The practical label shortcut is that 5% of the daily value or less per serving is considered low, while 20% or more per serving is high. Serving size is where the arithmetic often changes. Suppose a small container lists 700 milligrams of sodium, but the package contains 2 servings. Eating the entire container supplies 1,400 milligrams, not 700. The front may say natural, light, or made with vegetables. Yet none of those words answers the sodium question. Compare the same amount of 2 similar products, then check how much you will actually eat. Start with the item you use most frequently instead of rebuilding the pantry in one day. If canned soup appears 3 times a week, compare labels and test a lower sodium version. If sandwiches are daily, look at the bread, meat, cheese, condiment, and pickle together. The sodium may come from several ordinary layers, rather than one obviously salty ingredient. A homemade meal can also be high in sodium if seasoning packets, bouillon, bottled sauce, and cured meat all enter the same pot. Restaurant meals require a different strategy because the label may not be in front of you. Nutrition information is often available online for large chains, while smaller restaurants may be able to serve sauce or dressing separately. Choosing a smaller portion, taking part of the meal home, or avoiding a second salty side can be more realistic than searching for a perfect dish. A temporary increase on the scale after a salty meal may reflect retained fluid, but sudden or persistent swelling and breathlessness deserve medical attention. Low sodium and no salt added are useful label clues, but they are not a guarantee that the whole meal fits. Draining and rinsing some canned vegetables or beans can remove part of the sodium, provided the food still fits the individual plan. Herbs, garlic, ginger, lemon, pepper, and other salt-free seasonings can build flavor gradually. People who have swallowing trouble, poor appetite, or unwanted weight loss should not receive a bland, restrictive diet without professional guidance, because eating enough also matters. Be cautious with salt substitutes. Some replace sodium with potassium chloride. That may be unsuitable for a person whose potassium is high or whose kidney function and medicines affect potassium balance. The word substitute does not mean universally kidney safe. Bring the container or a photograph of its label to a dietitian, clinician, or pharmacist before making it a daily habit. The sodium check changes the question at dinner from "Did I add salt?" to "How much was already here?" The last habit requires the same shift. Many people say they rarely eat dessert while drinking sugar in tea, soda, juice drinks, or flavored coffee. The sweet taste is obvious, but the connection to kidney health is often described incorrectly. Sugar does not scrape or poison the kidneys on contact. Persistent high blood glucose is the real concern. Over time, high blood glucose from diabetes can damage blood vessels and filtering units in the kidneys. High blood pressure often travels with diabetes and adds another source of injury. Approximately 1 in 3 adults with diabetes has chronic kidney disease, and early disease commonly produces no clear symptoms. That is why the final habit matters most for viewers with diabetes or pre-diabetes. But it is also why a video cannot diagnose the problem from thirst, fatigue, or frequent urination. Begin with what is easiest to drink without noticing. Soda, sweet tea, energy drinks, flavored coffee, and many fruit drinks can deliver added sugar quickly while providing little fullness. A bottle that looks like one portion may contain more than one. 100% juice has no added sugar by definition, but it still concentrates the natural sugars from fruit, offers less fiber than whole fruit, and can be easy to consume in a large amount. The label and the serving both matter. The most useful first experiment is not a permanent ban. For 1 week, identify the drink that supplies added sugar most often. Order a smaller size, dilute sweetness gradually where appropriate, or replace one daily serving with a beverage that fits the medical plan. Water works for many people, but anyone with a prescribed fluid restriction should follow that limit rather than assuming more water is always better. Unsweetened tea or coffee may fit some plans, while caffeine, sleep, and medicines can create other considerations. Keep the experiment observable. Write down the container size and whether a refill was added. A mug prepared at home can change from day to day, as spoonfuls are poured without measuring, while a cafe drink may contain several sweetened ingredients under one name. Reducing sweetness in stages can be easier on the palate than expecting an abrupt change to last. The result to watch is a sustainable reduction, not a single day of perfect eating followed by a return to the old pattern. Packaged foods deserve a second look at the line labeled added sugars. The Food and Drug Administration uses 50 grams as the daily value on a 2,000-calorie reference diet, and 20% of that value or more in one serving is considered high. This is a comparison tool, not an allowance that everyone should try to reach. Flavored yogurt, cereal, sauces, snack bars, and baked goods can contribute even when they are not presented as dessert. Refined carbohydrate portions also matter, especially for someone managing glucose. White bread, crackers, pastries, large servings of white rice or noodles, and many breakfast products can raise blood glucose rapidly. That does not make one food morally good and another bad. It means quantity, meal context, medication timing, culture, budget, appetite, and the person's glucose response should shape the plan. Whole grains, beans, vegetables, and intact fruit can provide more fiber and may replace highly refined choices. But kidney disease removes the possibility of a universal swap list. Potassium, phosphorus, protein, and fluid needs vary by stage, laboratory results, treatment, and medicines. A large bowl of bran cereal, a potassium-rich smoothie, or an unrestricted serving of beans may sound healthy while conflicting with one person's renal diet. A renal dietitian can preserve variety without pretending that every patient needs the same restrictions. A safer plate change is specific and measurable. Keep the familiar meal, reduce the oversized refined carbohydrate portion, and add an appropriate vegetable or protein chosen for the individual plan. Eat from a plate rather than a package. Pair carbohydrate with the rest of the meal instead of turning it into the entire meal. If glucose is monitored at home, discuss the pattern with the diabetes team rather than changing medication to chase one unusual reading. Most importantly, do not wait for symptoms to settle the question. Early kidney disease may be silent. People at higher risk can ask about two basic checks: a blood test used to estimate glomerular filtration rate and a urine test for albumin. Diabetes, high blood pressure, heart disease, and a family history of kidney failure are reasons to discuss testing frequency with a health professional. A normal-feeling morning cannot replace those measurements. Now return to the four objects from the beginning. The remote asks whether rest has expanded until movement nearly vanished. The pain reliever asks whether the active ingredient, dose, timing, illness, and kidney history have ever been reviewed together. The soup can asks what the sodium line says after the real serving is calculated. The sweet drink asks whether added sugar has become an invisible daily event. None of these checks requires panic, and none promises that one change will repair kidney damage. They turn a vague warning into information you can use. During the next 24 hours, record how long you sit, photograph every medicine label, check sodium in the packaged food you eat most, and count the sweetened drinks you actually finish. Then choose one change that is safe enough to repeat. Perhaps that means a short walk after lunch with a cane or companion. Perhaps it means asking the pharmacist about ibuprofen before buying another bottle. It may mean comparing two soups, or making the first glass of tea unsweetened. The action should match the risk you truly have, not the fear created by a dramatic headline. If you already have kidney disease, diabetes, difficult to control blood pressure, swelling, heart disease, abnormal potassium, or several prescriptions, involve your care team before making major changes to food, fluid, medicine, or activity. Seek prompt care for a major drop in urination, severe shortness of breath, chest pain, confusion, persistent vomiting, or rapidly worsening swelling. General education is most useful when it helps you recognize the next good question, not when it replaces medical care. Growing older does not require perfection, and protecting the kidneys is not a single kitchen trick. It is a series of ordinary decisions made with better information. If this explanation helped you see one familiar habit differently, share it with someone who keeps a pain reliever nearby or never checks the serving size. Then begin your own 24-hour audit. One honest observation today can become a safer conversation, a more suitable meal, or a movement routine you can still be following months from now.